I know you're here to listen to the amazing talks, but I want to say three quick things. First, my name is Mohanish. I'm the co-director of the UNC's MD PhD program. Second, I have the privilege of working with amazing students who come to our program from all over the country and who come here to do their combined MD as well as PhD degrees. They spend about 8 or 9 years in this program. We get to know them very well. And at the end of it, they become physician scientists who are ready to tackle the world's problems. So really, hats off to the students over there. A big round of applause for the students over there and the students who are sitting in front here. In particular, Kyle and Rochelle are the leaders of the mini med school. These students do a lot beyond that for the community. And this is one of the several things our students do for the community, which we're incredibly proud of. Which brings me to the third thing, which is this program would not work if you guys were not here. So I'm just thrilled to see so many of you here and many others in Zoom. So thank you. Enjoy.
Thank you, Dr. Deshmukh, for the great introduction. My name is Rochelle. I'm one of the co-directors of Mini Med School.
And I'm Kyle.
And we're just very delighted that you all are here and are interested in learning more and just trying to engage with information. So we really appreciate your attendance, and we hope to continue to see you for the remainder of Mini Med School this year and next year to come. So before we get started, we are introducing a new segment to Mini Med School, a Mythbusters segment, where we are trying to equip the community with best practices to understand how to navigate all the different kinds of medical and health information that might be presented on the internet and online. And so for that purpose, we have our very own Dr. Cambry Smith, who will be giving that talk for us in a bit. And so Cambry has a Bachelor's of Science in Nutrition Science from NC State, and she also has a background in biomedical ethics research and is broadly interested in clinician-patient communication about online health information, including mis- and disinformation. She matriculated into our program in 2020 and defended her PhD in health policy recently in November of 2025. So her dissertation was titled Helping Clinicians Address Digital Information About Contraception with Adolescents, and her goal is to improve person-centered communication about patient-identified communication, especially with younger patient populations who often access health information online. She's published nearly 30 papers in a wide variety of clinical, public health, and social science journals, and she's looking forward to returning to clinical rotations later this spring as a third-year med student. So without further ado, let's welcome Cambry.
Okay, hello everyone. Thank you so much for being here. I'm really excited to be introducing this new segment titled Mythbusters. So it's a really confusing time to figure out who and what to believe about health and science. And there's a lot of mistrust and a lot of confusion. And we're really, really glad that you're here. And that's because this is one way in which we try to connect with the community, try to help address some of your questions and concerns, and dive into your health priorities and whatnot. So we encounter questionable health claims all the time, regardless of whether we're searching out information intentionally or we're passively talking or scrolling. And so sometimes people think, oh, it's only if I'm like Googling health information that I'm going to see this, but we encounter this much, much more passively in many domains of our life. And there's a lot of conversation about misinformation. Sometimes people think that misinformation is new. However, it's very, very old. There's always been medical misinformation. There's always been people who are saying things that are not necessarily true about medicine and science. However, in the age of the internet, this really facilitates the spread of false information. And this can happen, as you all know, very, very quickly. The emergence of AI makes this even more complex, where we're seeing kind of fabrication of reality before our very eyes, and it's very difficult to discern what is true and false. So I'd like to talk a little bit about information quality and how I and other information scholars think about kind of the different buckets of health myths and disinformation. So if we think about this spectrum from false claims or claims that really have no evidence to claims that are true or have very high evidence to support them, and then we think about this other axis of good intentions to bad intentions, what we have here in this quadrant is facts spread to promote truth. And ideally, this is where we are most of the time. Ideally, this is what we share with one another and what we're hearing from people all around us. However, we are human and we often get things wrong. We don't mean to get things wrong. And sometimes we share things that are incorrect. It can be harmful or not harmful, but the idea is that misinformation is false information spread without any intention to harm anyone. Down here is this interesting quadrant called malinformation, and I would say most people don't really think or hear much about malinformation. But this is the idea that there are some claims that maybe there's a fact out there or a very little amount of evidence for a certain idea, and then it's blown way out of proportion or it's used in some sort of manipulative way. So maybe there's one study that says this, but the rest of the evidence is saying, no, that's not what we found. And when that's used to confuse people, that's malinformation. The really bad quadrant is disinformation. And so that's when people are deliberately spreading false information for some sort of agenda, and this can be very dangerous. And then the last kind of area of misinformation is misleading information. And the reason that it's in both the blue and the green is because we don't always know if it's true or false. So a lot of times this is somebody saying, oh, this thing happened to me. And maybe it did, maybe it didn't, in terms of, well, they probably know if something happened to them, but they're saying this thing caused this in my body, for example. And it could have, or it could have been something else that was causing that problem. But then those personal experiences are broadly kind of generalized to everybody else. Like, I think this thing happened to me, therefore nobody should do this or nobody should take this medicine. And this is what we see a lot on the internet, where people are kind of sharing experiences and then extrapolating them to broader groups of people. So I wanted to provide some kind of red flags, yellow flags, and green flags for all of you as you're browsing online, or even listening to friends and family members. But the first is whenever you see posts that are saying, using very causal language, so something like, this thing caused this, that might be a good sign to slow down and try to do a little bit more searching. Anytime somebody's promoting or selling products, it doesn't mean that they're always spreading mis or disinformation. It just means that they probably have an additional sort of incentive to get you to believe their information. If you do a little bit of searching into accounts, sometimes people have ideological or kind of these non-science-based agendas, and it might not always be obvious. The name of the account might be something where it seems like it's trustworthy, but then you do a little bit more research and you're like, ooh, maybe not. Anything where you are seeing like encouraging mistrust of the entire medical system, or something like you can't trust any doctors or you can't trust anyone in science, that might also be something to, again, pause. And you all are here at kind of a public science event, so hopefully you have a little bit of trust in medicine and science, but some of those around you might not necessarily. Anything where they're promising like things they don't want you to know. And then lastly, miracle cures or things that seem too good to be true. Oftentimes they are. Some yellow flags. So the first one is people who appear to be healthcare providers. Anyone can claim to be a health provider on the internet. People can put on white coats. People can put a stethoscope around their neck. They can say they're a doctor. They're not necessarily. And then sometimes somebody says they're a doctor and maybe they're like a naturopathic doctor, or they're a different type of doctor than what you would expect. So it's helpful to go and learn not only what their degree is, but also what their specific training is, because we also see people who train in one area of medicine and they're giving very detailed advice in a completely different area of medicine. So maybe they've trained as, I don't know, like an orthopedic person and they're providing gynecologic advice or something like that. So just double check what people's actual training is. Again, that personal experiences that are brought into everyone, recommendations to stop your medical treatment without talking to a clinician. And then supplements, also be very wary of those. Those are not proactively regulated in the US. So you could have a bunch of powder in your supplement and like bad powder or things that are not what you think they are. And until that gets, like people have a real problem with it, it's not going to be proactively regulated like medicines are. Finally, green flags, so content from reputable healthcare organizations. Hopefully you think UNC is a reputable healthcare organization, different medical societies. We're asking our physician presenters to share trusted sites that they recommend for their patients throughout this Mythbusters series. If you can verify that someone is a healthcare provider who's in a relevant clinical area and then promoting medical guidelines that are based on lots and lots of studies. There are a lot of other fantastic professionals out there, people who are scientists, investigative journalists, et cetera. You know, things that are promoting measured and balanced perspectives, and then citations can be a really good sign that they're basing their recommendations on research. So if you're confused about a health claim, the first thing we would recommend is, you know, ask a clinician. It can be very difficult to get an appointment at your clinician. And so sometimes these are things that you can message your provider about on MyChart or something like that, where you don't have to go in for a specific visit. A lot of people say, oh my gosh, everything on the internet is terrible. That's not true. There's so much good stuff on the internet. And finding the right sources is super important. The American Academy of Pediatrics, I do a lot of work with pediatric populations. They have a wonderful website, and they're also on social media promoting evidence-based guidelines. Mayo Clinic and Cleveland Clinic have a lot of patient-facing resources. FamilyDoctor.org is run by the American Academy of Family Physicians, and these are all patient-facing resources that might be helpful for you. And you can, again, follow these people on social media and generally can improve your algorithm, get some good evidence-based information in there. Again, you're here. We're super excited. We hope you come to the rest of our series. If you have some sort of question and you can't find anyone to help answer it, and we can be helpful finding some sort of expert at UNC or something like that, just reach out to us and we can see how we can help you. And then lastly, you know, chatbots do have their purpose. Some of them can be very, very helpful for patients. Things like, what should I ask my doctor before going into a visit? Sometimes people get really complex health information and they get confused after their visit, and talking with something a little bit more interactive can help clarify some questions. However, before changing any of your health behaviors, you should talk to a professional, just because those chatbots can also be inaccurate. So as we mentioned, Mythbusters will be woven throughout all mini med school sessions. The idea is that each of our presenters will share common myths that they see in their areas and give you good information about that. And then again, we've also asked people to hopefully give you all some good patient-facing resources for each sort of each topic that we are discussing in this series. So thank you all so much. And I believe Yousif is next.
All righty. Thank you for that, Cambry. Really, really great talk. I hope that's kind of setting the scene and the stage for what is more to come. We're really excited about this coil, and Cambry is one of the experts in this. So I really hope that this kind of sunk in with a lot of us. So I'm going to introduce Yousif. He's an MD PhD student, obviously, here at UNC, and he just defended his thesis, which sought to improve diagnosis and prognosis of rare eye diseases using mathematical transformations. He has a strong interest in ophthalmology, and he hopes to work as both a scientist and a physician in the near future. A little fun fact, he also drove across the country in a motorcycle once.
Hello, everyone. Thank you, Kyle, for the introduction, and thank you for that talk, Cambry, as well. Hi, everyone. So today I'll be leading our physician speaker who will be discussing diabetic retinopathy. And what I thought would be really helpful is we just go over overall vision health and how that changes with age, so everyone has a general understanding what to expect and maybe what's not normal. So for the topics for today will be just vision health and aging, clinical care and prevention, as well as how to protect your vision. So everyone's vision can change with age. And as you age, you may notice some changes in your vision, and vision changes can make it difficult to perform activities of daily living. This can be anything like reading or using a computer, walking safely, taking medications, performing self-care, household tasks, and even driving a car. And having difficulty doing everyday activities can impact the ability to maintain independence and could contribute to anxiety and depression. So if we appropriately address your vision changes, you can maintain your everyday activities and independence and reduce anxieties. So some changes in vision are common as we age. These changes include losing focus, making it harder to focus on vision up close, noticing declining sensitivity, making it harder to distinguish colors, such as blue from black, or where an object ends and its background begins, and needing more light to see well, and more time to adjust to changing levels of light. So going from a room that is dark to one that is brightly lit. Some people can age without ever experiencing changes in their vision or vision loss. So that is possible. So many of these vision changes can be corrected. Vision changes don't have to stop you from enjoying an active lifestyle or maintaining independence. And many times vision changes may be corrected with glasses, contact lenses, or improved lighting. So for example, increasing the lighting in your house can help you avoid accidental trips and falls. Night lights or automatic lights are also great, and they can be helpful when the room is darkened and it's nighttime. And despite all of this, I do want to make it clear that complete vision loss and blindness are not a normal part of aging. So as you age, we are all at an increased risk for this, but there are a lot of things that we can do for this to prevent it. So we're going to go over a couple of diseases, and the first one that I want to discuss is age-related macular degeneration, also called AMD. This image on the left is actually what it looks like for anyone with healthy vision, seeing, the world all around them. And then on the right, this is what it looks like for someone with age-related macular degeneration. And this is actually a common eye disease among people aged 60 or older, and it gradually destroys the macula. The macula is the small sensitive area located in the center of the eye or of the retina and is needed for sharp central vision and for seeing objects clearly. And there's actually two forms of AMD. There's dry AMD and wet AMD. In dry AMD, the macula slowly breaks down and can cause blurry central vision, while in wet AMD, abnormal blood vessels start to grow and can leak, which cause vision loss. Some symptoms, if you do have AMD, include blurry vision, straight lines appearing crooked, and interestingly, AMD does not cause any pain. So it does kind of look like a painful manifestation of a disease, but no pain there. And there are some treatment options for AMD. So you can take special vitamins and mineral supplements. Laser eye surgery is an avenue as well as eye injections and photodynamic therapy. I'm sure many of you have heard of cataracts. This is what vision looks like for someone with cataracts. And over time, the cataract may grow larger and cloud more of the lens, making it harder to see. And a cataract can occur in one or both eyes. And some symptoms include cloudy vision, as you can see here, colors not appearing as bright as they had previously, and light from oncoming headlights causing glare in one or both eyes. And some treatment options include eyeglasses, better lighting, anti-glare sunglasses, or a magnifying glass. And if none of these options help, cataract surgery is an effective treatment. So I know people say, oh, surgery, some people get worried, but cataract surgery is one of the most common surgeries performed in the United States. And the surgery involves removing the cloudy lens and replacing the lens with an artificial one. And some people with cataracts may never need surgery, and many are able to just postpone the surgery for many years. This here is what having diabetic retinopathy looks like, and our physician speaker will speak about this more. And it really occurs when diabetes damages those tiny little vessels in the back of your eye, in the retina, which is the light-sensitive tissue. The longer a person has diabetes, the more likely it is he or she will have diabetic retinopathy. And if untreated, vision loss or blindness may occur, as you can see here. And some symptoms include blurred or blocked vision. And there are also no early warning signs as well, at least from a patient perspective. You come in and do prospective assessments with your healthcare provider, you can prevent this from happening if you do have diabetes. And because if the disease is detected early, timely treatment and follow-up can reduce the risk of vision loss like this by up to 90%. And some of the treatment options include laser eye surgery, eye injections, and conventional surgery. And here is our last disease that we'll go over. This is glaucoma. This is what it looks like if you have glaucoma. And it can develop in one or both eyes, just like cataracts. And it affects the peripheral or side vision. As you can see on the side, there's some darkening and clouding. It's kind of hard to see in the periphery. And it's associated with elevated. And glaucoma is associated with elevated pressure in the eye, but the effect of the pressure can vary from person to person. And some symptoms of glaucoma include that it can be difficult to see objects on the side, obviously as you can see in the image, and if left untreated, this will eventually affect the central vision as well. And some treatments include eye drops. So this is the most common medication treatment for glaucoma. And it's important to note that you need to take the medication, these eye drops, as directed regularly. It's very important not to miss any dosages. And laser surgery or conventional surgery is sometimes also used for glaucoma. And glaucoma can't be cured, but there are a lot of options to mitigate progression and manage it. So there is still something that can be done. So now that we went over kind of a couple of the common vision-related disorders, it's just good to understand what technically is low vision. So low vision is defined as visual impairment that is not corrected by standard eyeglasses, contact lenses, medication, or surgery. Additionally, low vision may interfere with the ability to perform everyday activities. So people with low vision may find everyday tasks difficult to do, like the ones we had mentioned earlier. And few people develop low vision after eye injuries or even birth defects. Most people develop low vision because of eye diseases or as previously discussed. And while vision that's usually lost can't be restored, many people can make the most of their remaining vision. There's also a lot of options for vision rehabilitation. So this teaches people about services and devices available to help them adapt to their vision loss and maintain what they still have. So I think it's really good that we go over kind of the specifics of vision loss with aging, tying this all together. So, I'm sorry. As I previously mentioned, these age-related eye diseases often have no warning signs or symptoms in their early stages. But if they're detected and treated early, vision loss and blindness can often be prevented. So a comprehensive dilated eye exam can really be helpful, and everyone aged 50 or older should have a comprehensive dilated eye exam. Depending on your specific eye health needs, your eye care professional will tell you how often you should have one as well. So dilated eye exams are not the same as the ones that you get for glasses or contact lenses. Dilated eye exams involve dilating the pupil and are needed to determine if your vision is normal and if your eyes are healthy. So a dilated eye exam can detect eye diseases in the early stages, as well as common vision problems that you may be corrected with glasses or contact lenses. And some of the other common vision problems that a dilated eye exam can help with are also listed up here. So presbyopia, farsightedness, nearsightedness, and astigmatism. And this is exactly what a dilated eye exam will look like. Basically, drops are placed in the eyes to dilate and widen the pupils, which is the round opening in the center of the eye. The eye care professional will use a special magnifying lens to examine the retina, which is the light-sensitive tissue at the back of the eye, and the optic nerve, which is the bundle of fibers that send signals to the retina, or from the retina to the brain, for signs of disease. And so after examination, your close-up vision may be blurred for several hours. So it's important to have, some people like to organize transportation after a dilated eye exam, so they're not left driving on the road. Their eyes are dilated, a lot more light's coming in. Sometimes people only just need sunglasses, and that is good enough to kind of, let them manage getting home. But that's something for you and your healthcare provider to discuss and figure out, and also whatever you're comfortable with. And I think this is a nice illustration of exactly what that looks like right here. So note that Medicare will pay for a dilated eye exam for individuals with diabetes, detecting glaucoma if you have diabetes, and if you have a family history of glaucoma and are aged 50 or older. So the most important thing that you can actually do to protect your vision is to visit your eye care professional and get that dilated eye exam. There's nothing else that's more effective and helpful than a dilated eye exam. Be sure to share any medications that you are taking. Some may have side effects that may affect your vision. They can also tell you how frequently you need to come back for follow-up examinations. Your eye health is related to your overall health, so it's also good to take care of yourself and work out as needed and have a good diet. And that's actually exactly what we'll go over right here. So these are just some overall things that you can do to help yourself maintain good eye health. So of course, limit smoking, have a diet rich in green leafy vegetables and fish. Try to be physically active every day, working in the garden, taking your steps, wherever it may be. Also, it's really important to control diabetes if you do have it. You want to be part of that 90% that do prevent any further progression of vision loss. And when outside, wearing a brimmed hat or wearing glasses as well to protect yourself from strong sunlight. And here are just some questions to ask your healthcare provider. So you can always ask, are you at higher risk for eye diseases, and kind of understand where you're at compared to other people, and do you need to do regular visits or not? What changes you can expect in your vision? Also, you can ask, will your vision get worse? How they can be corrected, what you can do to prevent that, and what you can do to protect your vision, and what other lifestyle changes you can implement. And so just to recap some of the most important points from this talk, remember, some vision change is normal as you age. However, vision loss and blindness, like complete vision loss, is not a normal part of aging. And if you're 50 years or older, it's good to have a comprehensive dilated eye exam, and make sure you ask your healthcare professional questions. I find that when patients are really involved with their healthcare provider, it seems like they can both get more information from one another and help each other more. So with that, I'm happy to take any questions. Yes. Sure.
So my family maybe I've always wondered if there's or if there even is some sort of early detection of eye things, or especially I guess having pretty good eye vision, and then you can just sort of exactly what
Sure. Thank you so much for the question. Yes. So the first question was, will there be ways to predict if any of us will have glaucoma at some point in our lives, whether it be early in our life or later? And so there's actually a lot of, I guess there's a lot of hope in ophthalmology research right now. There's a lot. I'm sure you've gone to an eye care professional a lot growing up. They do a lot of things like getting images of the back of your eye, also the front of the eye. So there's been many advancements, especially using AI to predict how someone's retina will it thin in the next 5 years, will it, remain the same thickness and very healthy for the rest of their life. So to give you an exact answer, I'm not so sure, but I'm very, I have a very positive feeling about the trajectory of eye care and our understanding of, how things will progress, or understanding how these eye diseases will progress for patients. And then I think the second question was,
Oh, like lifestyle is, I guess, if you do sit in front of the TV.
yeah, that's funny. Yeah, there's actually, so I don't know about, I also heard the same thing. So the question was, or the point was that growing up, um, a lot of comments about watching TV and staring at a screen for too long. I also heard that a lot growing up. And there is actually this thing called like the 20-20-20 rule. So about every 20 minutes, if you're working at a screen, you can take a 20-second break and just stare 20 feet ahead from you. And that way you can kind of relax your eyes from staring at a screen for so long. So if you are very, you're trying to be cautious of staring at a screen for too long, 20-20-20 rule is a great one to do. Of course.
Is there value to show what is the value of sitting like an eye?
I think it depends. I actually don't, I think yeah, sorry, I need to repeat that question. So the question was, is there a benefit to doing a dilated eye exam versus doing retinal imaging? And I think that's your physician or your healthcare provider will determine that. I think it's hard to say. I'd imagine your physician will do, or healthcare provider will do one of those first, and then if need be, do another one to confirm whatever they suspect from the first one. I think that's a way that they can save money and also save everyone's time not doing additional tests that aren't needed. Paige, go ahead.
We have someone on Zoom regarding sunglasses. At what age?
From my understanding, you should, okay. Oh, well, we got the question. Okay, say it again. So the question was, at what age should we start wearing sunglasses, and what is the recommendation for the type of sunglasses, any type of specifications? I believe it's about 99 to 100% blocking of UVA and UVB light. If you can look that up, I'm sure when you buy sunglasses, it's somewhere in the specification. So make note of that. And then as far as an age range for starting to wear sunglasses, probably, always. I don't think that can hurt. And if you get a pair of sunglasses you like, it'll look cool. So why not? Sure, go ahead. Final question, okay. Yeah, blue light glasses. Okay, so the question was, what are my thoughts on blue light glasses? I don't know enough about that. I think that's what people wear when they're staring at a screen for too long and they want to make sure they can sleep well at night or something. They're like their circadian rhythms or something. Yeah, I'm so sorry. I don't know enough about blue light glasses. Yeah, I can take you. Why not? Yeah.
He always told us there's a band that has been knocked.
Sure.
So what kind of bands is there be in your eye that it's knocked loose?
Yeah. Okay. Interesting. Yeah. So we had someone in the audience mentioned a family member with had an injury when they're an infant, and I think I don't know what kind of specific biological injury that is, but Yeah. Oh gosh, I'm so sorry. Oh gosh, that's quite the story. Yeah, interesting. Um,
He was also explained to us like the band in the back of the eye got damaged in the fall. He had that surgeon correct that, and that makes it.
interesting. Well, I hope he's able to manage his vision now. Yeah.
Band was being brought.
Sorry, do I need her? Yeah.
I apologize. We can probably talk after. This sounds like a very specific question. But I just want to make sure that Dr. Lindeke-Myers is able to get through the rest of his talk. But feel free. We can certainly talk afterwards. Thank you for the question. So without further ado, thank you, Yousif, for such a great student talk. So Dr. Aaron Lindeke-Myers is a comprehensive ophthalmologist and cataract surgeon at UNC. He grew up in Hillsborough and earned his bachelor's at Hampshire College. During college, he discovered his passion for ophthalmology in Ghana, where he spent a summer volunteering providing eye care in rural villages. He earned his MD with Latin honors from Emory School of Medicine and completed his ophthalmology residency at Duke University, for which we'll forgive you for. Beyond his clinical duties, Dr. Lindeke-Myers has presented at national ophthalmology conferences and published numerous journal articles on maculopathy, ocular drug safety, and patient perspectives in ophthalmologic care. Outside of work, Dr. Lindeke-Myers enjoys spending time with his family, exploring the Triangle's flourishing food scene, trail running, and mountaineering. Without further ado, I'll welcome Dr. Lindeke-Myers to the stage.
All right. Thank you all for being here. And thank you, Kyle, for the wonderful introduction, and to Yousif and Cambry as well for their presentations. Before I forget, just a couple pieces on those. Sorry, I don't have a slide for this, but on Cambry's presentation, some of the sort of social media or online resources I like in ophthalmology, certainly American Academy of Ophthalmology is always a great trusted resource, and they have a lot of, like, I consult with things from them sometimes on my end, but they also have a lot of public and patient facing information about all sorts of eye conditions. And then for a more sort of light take on things, there's Dr. Glaucoma is his online personality. Some of y'all are probably familiar. He's a comedian and an ophthalmologist, but he presents very accurate healthcare information, often sort of healthcare policy and related information in a very humorous and entertaining way. So it's spelled, if you look up doctor and you start typing in glaucoma, he'll probably pop up. It's Glaucoma. You'll see him on there. But okay, real quick to begin, I just wanted to discuss, what is an ophthalmologist and what's an optometrist? That's a point of confusion for a lot of people. Optometrists are doctors. They're doctors of optometry. Some go by doctor, some don't. That's their personal choice. But I know sometimes people are confused about whether they are physicians or not. They're not physicians, but they handle a lot of things with the eye, contact lenses, glasses, sort of routine eye examinations, as well as some medical disease management. Whereas ophthalmologists are physicians, meaning they completed medical school, and they do all the things optometrists do, plus some more complex disease management, including procedures and surgery. Both optometrists have some subspecialties like pediatrics and a few others, but ophthalmologists have quite a few subspecialties, including retina specialists, glaucoma specialists, cornea specialists, pediatrics, neuro-ophthalmology, ocular oncology. There's even several more beyond that. You'd be amazed at how many different subspecialties we managed to cram into this little tiny organ in your head. But they all, there is a not unlikely chance that if you are diagnosed with a ophthalmology disease, that you may end up seeing one of these subspecialists, and they're really the experts in that specific area. So don't be too alarmed if your ophthalmologist refers you out to a different ophthalmologist. That's pretty common. So why discuss diabetic eye disease? That's the main topic I'm going to discuss tonight. Well, it's remarkably common. About almost 15% of adults in America have diabetes mellitus, to be clear. There's another more rare type of diabetes that you probably won't hear about, but diabetes mellitus is what we're talking about today. So in 2021, at least, about 15% of Americans had diabetes, and those were uptrending numbers at that time, so it could be more now. And that percentage just about doubles for Americans who are over the age of 65. And then about a quarter of diabetics have diabetic retinopathy, which is one of the main things I'll be talking about today. And most importantly, one of the reasons to educate folks on this is, according to the CDC, about 90% of vision loss from diabetes can be prevented. So that's what I'm going to talk a little bit about today. And then the other reason to talk about it is it's a disease that can impact a lot of different parts of the eye. So through talking about it, I get to give you all a little sort of tour of the eye and a variety of different eye diseases that will actually build on a lot of things that Yousif touched on. So that's great. Really quickly, diabetes, bird's eye view of it. It's the inability of the body to use and store glucose or sugar properly, which results in high blood sugar levels, relates to insulin. Insulin is the main regulator of blood sugar. That's why you often hear about insulin relating to diabetes. One of the main themes you'll hear me touch on over and over again is that high blood sugar damages blood vessels. And that can affect any part of your body. Just about every part of the body gets, is attached to some blood vessels. So in the big terms, it could cause things like stroke and heart attack, can cause kidney damage, nerve damage, and then a lot of other conditions, as well as a lot of eye conditions that we'll talk about tonight. Do I have diabetes? How would you know? Well, it's often asymptomatic, so it can be hard to know for certain. If you do have symptoms, it can be relating to lots of thirst or frequent urination. You may get more infections more often than other people. Now, there's other causes that could be cause that as well. Blurred vision, we'll talk all about that tonight. And then some people learn they have diabetes through really severe episodes, like diabetic ketoacidosis as an example, which is an emergency that causes confusion, abdominal pain, nausea, and requires sort of very urgent hospitalization, typically for IV insulin to correct. That would not be a subtle presentation, but a lot of cases it is a very subtle thing. So the main thing that I recommend is just getting routine blood work screening as you get older. And the hemoglobin A1C is a frequent blood test that measures for diabetes. It's a sort of an average of what the blood sugars have been over the last 3 months. It's measured in a percentage, and percentage above 6.5% is the definition of having diabetes. That translates to an average blood sugar of about 140 milligrams per deciliter, which is the common blood sugar measurement used if you're ever pricking your finger and checking the blood sugar that way. So that's the correlation there. Whereas like a hemoglobin A1C of 8.5 is about average of 200 milligrams per deciliter. So that's how those percentages translate. The doctors are always going to be excited about talking about the percentage, though, because it gives us this average value, whereas a single blood glucose reading is not as informative. All right, now I talk a little bit about healthy eye anatomy. So I like to use the analogy of the eye as a camera. if you think of it that way, the light rays enter the eye and are focused. The goal is to focus those light rays onto the retina, which is at the back of the eye. The retina is like the film of the camera. The cornea, which is kind of like the clear windshield at the front of the eye, and the lens, which sits just behind the iris through the pupil, which is the pupil just refers to the hole in the middle of the iris. It's not an actual physical thing. It's just the hole in the center of the iris, which the lens sits behind. Anyway, the cornea and the lens work together to focus the light rays onto the retina. So those are functioning sort of as the lens of the camera. And then the retina is that light sensitive film, or kind of, it's almost like wallpaper that lines the back part of the eye. And it sits on a highly vascular bed of tissue called the choroid. And you'll hear a lot about how important those blood vessels are for the retina. The retina's job is to convert the rays of light into neural impulses, which are then passed along the optic nerve. You can see the optic nerve come out of the back of the eye there. The optic nerve is sort of like the HDMI cable that connects the camera of your eye to the screen, which would be your brain, basically. That's where the images are displayed, if you will, although it's a lot more complicated than that. Those images are built up through a very complex neural process and involves a lot of different areas of the brain, but that is beyond the scope of my presentation tonight. That's the sort of quick eye anatomy here. Oh, and one other thing you can see on the picture on the left, you see something called zonules there. It's a fun word to say, but also it's the zonules hold the lens into place, and they get brittle with age, which, coming back to one of the things Yousif mentioned, of you stop being able to focus close up anymore as you get older. That's because the zonules and the lens itself both get more brittle, and the lens changes shape. That's what allows me to look at my hand right now and then look off to the wall over there and focus on each, as my lens is literally changing shape to focus the light rays in a different way. And as that really over the age of 40 is when that starts to get a little brittle. So I have at least one patient a day in my clinic who comes in panicked that they can't read close up anymore and they think they're going blind or something like that, but it's actually just some normal aging changes that can start around 40. They may not start until 50, but don't be alarmed if around that age you stop being able to focus close up as well. All right, so how can diabetes affect the eye? A lot of different ways, and I'm going to touch on each of these in more detail here. Diabetes and cataracts. We heard a little bit about cataracts earlier. I'm just going to go over that again in a little more detail. It's a clouding of the lens inside the eye. The main risk factors for it are UV light exposure. So yeah, the earlier you start wearing sunglasses, the better, just reducing your overall UV light exposure. They don't have to be polarized. It's about just the UV blocking. Cigarettes are a well-known risk factor for cataract formation, and then previous eye injuries or surgeries. I don't mean LASIK. LASIK doesn't cause this. I mean like a surgery where they had to go into the eye for some reason, which usually from an injury, if that's happening at a young age, that can increase risk of cataract as well. Can be a normal part of aging. About 50% of Caucasians will have a cataract by the age of 75, and about 70% by age 80. Other races are a little bit lower on those percentages. Cataracts are more common in women. I'm not sure if that's understood why that is, but they're very, like I said, very common to occur, and they're relatively easy to fix in medical, at least in modern medical practice, with cataract surgery, which, as Yousif mentioned, is the most common surgery done in the US and is very successful. So it's not the end of the world if you have a cataract. How they relate to diabetes is that excess blood sugar can end up deposited in the lens and can increase the amount of clouding of the lens as well. So that is a it's very common for people with diabetes to get cataracts at a younger age than we might otherwise expect. Normal age to have start having cataracts, like I said, 60 to into 70s, but some people, it may not be till 80s or even later. Diabetes and glaucoma. So glaucoma is a tricky one. It's a pretty poorly understood. It's thought to be a group of different diseases, but that cause a kind of a characteristic pattern of damage to the optic nerve. But there's a lot of unknowns still about exactly what glaucoma is, or if it's multiple things that kind of have this same end result. But it is typically associated with high pressure in the eye. That's why we check the eye pressure anytime you go to see an optometrist or an ophthalmologist. And that high pressure is thought to sort of push on the optic nerve over time and cause damage to it. If anybody's ever had a faulty connection on their HDMI cable to some device, you'll know that you don't get a good picture when the cord starts to be damaged. So it's the same thing in the eye. It as Yousif mentioned, it starts peripheral vision is what's lost first, and that can be pretty hard to notice. So glaucoma screening is really important for folks who have a family history of it. And the way that glaucoma screening is performed is usually an eye exam where we visualize the optic nerve, and then if there's anything we're worried about there, we can get a scan of the optic nerve that can show us kind of the exact thickness in micrometers. And then there's a visual field test that can be performed as well that's good at recognizing these subtle peripheral visual field defects that can happen with early stages of glaucoma that you might not notice in your day-to-day life. One of the reasons why we care about glaucoma so much is that once you lose vision from it, we don't have a way to get it back. As with a lot of nerve-related injuries, we don't have a way to regenerate that nerve. And so prevention is the name of the game for glaucoma. You want to catch it early. And the vision loss, if allowed to progress far enough, will affect central vision. And I have seen multiple people with complete blindness from glaucoma, which is always very sad because, like I said, there's no way to, at the moment at least, no way to get that vision back. Diabetes, its connection to glaucoma is it makes it about twice as likely to occur. So if you have diabetes, 2 times as likely to get glaucoma. Different ways that we think that happens. High blood sugar can cause some debris and extra proteins to be circulating around in the eye that can block some of the drainage channels where the fluid in the eye is usually draining out of. There's reduced blood flow to the optic nerve with diabetes, and anything that makes the optic nerve more fragile is going to make it more susceptible to glaucoma. And then in extreme cases, really severe diabetes, usually diabetic retinopathy, can cause neovascular glaucoma, which is a condition in which new abnormal blood vessels grow over the trabecular meshwork, which is the drainage system for the fluid in the eye. So it's kind of the gutters of the eye, if you will, get blocked up by these new blood vessels that grow in the wrong places. And that can cause really severe pressure elevations really quickly. I'll talk more about that a little bit later. But that's the way diabetes is sort of connected to it. The way we know to treat glaucoma is to reduce the pressure in the eye. Like I said, it's usually associated with high pressure, although you can get glaucoma even with low pressure. And some people have high pressure their whole life and never get glaucoma. That's why I say there's some things we still have questions about in our understanding of it. But reducing the pressure in the eye can be achieved through drops or laser procedures or surgeries. Typically, we start with either a drop or the laser procedure. Those are less invasive. And if you keep the pressure well controlled, then there's a lot lower chance of any vision loss occurring from glaucoma. Diabetes and lens swelling. This is an interesting one that's specific to diabetes. Rapid blood sugar changes can cause the lens to change shape, to swell. And like I talked about earlier, when you focus close up or far away, you're changing the shape of your lens to do that. Thus, if you're unintentionally change the shape of your lens with high blood sugar, that will also affect your focus and what you're able to see. The picture I have up here is of myopia, which is just nearsightedness, a very common eye condition. But I put it up there to sort of illustrate what I mean by, if you can imagine the ray of light is passing through the lens and getting focused ideally directly on the retina, right where we want it to be focused. If you're nearsighted, that ray of light is focused a little bit in front of the retina. And so then you put on a pair of glasses or contacts to then bump that focal point back a couple microns so that it's back onto the retina. So if the lens inside your eye changes shape, it also, like I said, changes where the light's going to fall, and that will can cause, with these big blood sugar shifts, that could be from really low blood sugar to normal blood sugar, or more commonly from normal blood sugar to really high blood sugar. It can cause this acute blurry vision. I've had multiple patients who said that they knew their blood sugars were high because of their blurry vision, even before some of the other symptoms they were having. And then it will reverse. So there's no specific treatment for this other than getting the blood sugar back down. But it can take weeks to fully go back to normal. And having a different shaped lens in your eye is going to impact your glasses prescription. So if you do have diabetes, sometimes your optometrist or ophthalmologist might tell you, hey, we can't give you a new glasses prescription today. Your blood sugars have been too high recently. This is the reason. We don't want to give you an inaccurate glasses prescription. Glasses are too expensive to get inaccurate glasses. So this is why you might hear that if you do have diabetes and really high blood sugars. Diabetes can also cause double vision. This is a little bit less common, but there are 6 muscles around the eye. Don't worry, I won't test you on these later. I've been tested on them way too much. But 6 muscles that pull the eye in all different directions, allow it to rotate and do all kinds of really cool things. But each of those, there's 3 different nerves that control those 6 muscles. And the nerves come out of your brain, and they're supplied by really fine little small caliber blood vessels that can be damaged by diabetes. So sometimes people will, with diabetes, can have some damage to one of those nerves that then results in weakening of one or more of the muscles that move the eye around. That's usually only on one side. So that's why you get the double vision. If you have one eye that's not able to fully move in every direction anymore, and your other eye is still moving normally, then you might have eyes that aren't aligning anymore, and can result in double vision. Now, some people are born with eye misalignment, or some people can, there's other reasons that you can get eye misalignment. It's not usually diabetes, but if someone has diabetes and all of a sudden comes in with new onset double vision, that's usually the cause. It often reverses. It can take months, but it often reverses over about 3 to 6 months. If it doesn't always, though, and if it doesn't fully reverse, then we consider that a stroke. Could be a small stroke, but we consider it a stroke on one of those cranial nerves that controls the eye muscles. In terms of double vision treatment, there's surgery that can correct it, or that you can put prisms in glasses that bend the light a little bit to sort of align your double vision. But there's a lot of nuance in all of that, and it can be tricky sometimes to perfectly realign things. Before we go to diabetic retinopathy, the one other condition I'll talk about are eye strokes, by which I mean central retinal artery occlusions or central retinal vein occlusions. The central retinal artery and vein are the main pipelines of blood into the retina, and the retina is a very metabolically active tissue, meaning it's always these cells are always active. I mean, we are always processing visual information. Even with your eyes closed, you're still processing that, hey, it's dark. You know, there's not as much visual information with the eyes closed, but they're pretty much always on. So these are some of the most metabolically active cells in the body, and they thus require continuous supply of nutrients that's transported by the blood. Diabetes is a risk factor for plaque building up in vessels. That can happen like in your carotid arteries in the neck. And then if a small piece breaks off of a plaque in the carotid, it could get lodged in one of the vessels in the retina, causing a blockage and a stroke to the eye. Stroke meaning there's not enough blood flow and tissue dies. Or the other thing that can happen is if you get a plaque buildup, and that's what this picture is illustrating, plaque buildup in the central retinal artery going into the eye, it can compress, smush the vein that's sitting, kind of right under it. And then you can get a blockage in the vein that way as well, which causes the same end result. If you don't have blood flowing in and out, there's going to be a problem with not getting enough nutrients to the tissues, and they may die. And that's usually, it can be just an area, or it could be the whole retina affected by this. It's not common, but it is a pretty devastating complication when it happens, and diabetes increases the risk of that happening. Very minimal treatments available if this does happen. So just kind of taking care of the high blood sugars is the most important, and other risk factors for atherosclerosis, that plaque buildup. That's the most important thing you can do. All right, I'm going to talk about diabetic retinopathy here. Give me 1 second. Okay, so this is the most common type of diabetic eye disease. It's caused by damage to the fine retinal blood vessels. Once again, we're back to damage to the blood vessels caused by the high blood sugar is causing the problems here. More than, like I said earlier, more than a quarter of people with diabetes have some level of diabetic retinopathy. It may not be devastating, but at least some level of it. And the biggest risk factor is just how long you've had diabetes. For type 1 diabetes, which was used to be known as like juvenile onset, so it usually happens in people who are younger, and it's inability of the body to sort of produce enough insulin. For type 1 diabetes, it happens, or diabetic retinopathy occurs in about 90% of type 1 diabetics after 20 years of having the disease. Whereas for type 2 diabetes, which is the more common quote unquote adult onset diabetes, that's about 60% of people with type 2 diabetes will have some level of diabetic retinopathy after 20 years with the disease. Once again, time is most important, but severity of diabetes is a close second in terms of the risk of developing diabetic retinopathy. So that's why we're always harping on people who have diabetes to try and keep the blood sugars under good control, because it reduces the risk of damage to the retina and elsewhere in the body too. And then high blood pressure, smoking, high cholesterol, those other vascular risk factors are other big risk factors for damage to the retinal vessels as well. And they sort of synergize with the damage from diabetes to make it more likely to get diabetic retinopathy. Interestingly, hormone changes in pregnancy. So someone who's diabetic who gets pregnant is more likely to develop diabetic retinopathy. And then people with gestational diabetes, which is when diabetes develops while you're pregnant, you didn't have it before, but you develop it while you're pregnant. People who have gestational diabetes are at a higher risk of developing diabetic retinopathy sort of lifelong, even after, hopefully, well, if the diabetes never returns, then great, it probably won't happen. But often people with gestational diabetes get some other, type 2 diabetes later in life, and they're at a higher risk of diabetic retinopathy as well, which is, I don't know if all of that is fully understood why that is, but, and then the kidney, so diabetic kidney disease or diabetic nephropathy is another link with diabetic eye disease. This is not a causal link to the best of our understanding. It's just that the little vessels in the kidney are about the same size as the little vessels in the retina. So if you have diabetic retinopathy, it may be a harbinger that you're going to get kidney disease, or if you have kidney disease, there's a good chance you may get some retinopathy as well. But that's just an association. It's not a causal link there. A little bit more about the retina quickly. This is a simplified view of it here, but like I said, it's the wallpaper that lines the back of the eye, and it has rods and cones in it. Those are the photoreceptors and a lot of other supporting cells that help those photoreceptors work, that detect the light. And then you can see all those red and blue on the picture on the left, all those red and blue dots sort of at the top. Those are the blood vessels meant to represent the arteries and veins there and capillaries that link the two. And you can see there's a huge bed of vascular tissue sitting under the retina. As I mentioned earlier, it's just requires a lot of blood flow to stay alive. Basically, it needs those nutrients. Then the center of the retina is the macula, which is where almost all the vision you're using right now to look at me, that's in the macula. Most of it's the fovea, which is this very center little pit that you can see, that sort of divot there in the picture on the right. And that fovea is our central vision, and it's why your peripheral vision is not as clear, whereas the central vision, where the fovea is where we get that really sharp definition of our vision. So that's a really important area, and is the most metabolically sort of active area. So it needs that blood flow more than anywhere else even. Let's see. Good. So non-proliferative diabetic retinopathy is the initial stage of diabetic retinopathy. And with good control of blood sugar, there's a good chance that if you were to get diabetic retinopathy, you never progress beyond this. Most of my patients haven't progressed beyond non-proliferative diabetic retinopathy. I'll get more into why it's called non-proliferative in a couple minutes when we talk about the other form. But there is, this is still a retinopathy. There is still some damage going on there. And it's as I mentioned, the blood vessels, they can leak fluid, cholesterol and fat and blood into the retina when they are damaged. The picture on the left is a healthy retina. That's an actual photo. So that's what I spend all day looking at. And it's when they do the dilated exam or the retinal pictures, that's what you'll see. That yellow sun looking thing there with the blood vessels coming out of it, that's the optic nerve. The blood vessels all radiate out from there because that's where the central retinal artery and central retinal vein I mentioned earlier, that's where they enter the eye, is along with the optic nerve. That's that HDMI cable that plugs into the back of the camera here. And then that sort of darker red area that's just to the right of the optic nerve on that picture on the left, that's where the center of the macula and the fovea is. That's those really important areas for vision, is right that darker spot in the middle. This picture on the right shows a variety of different findings that can be seen in the non-proliferative diabetic retinopathy. Some of these, there's little yellow spots in the middle there. They're a little maybe hard to see, but where it says exudate, that's some of the cholesterol and fat leaking out of the vessels. And then there can be little, we call them micro aneurysms, which is when there's a little dilation in one of the blood vessels because of a weakening of the walls from diabetes. And we notice those along some of the blood vessels sometimes. And then there's little hemorrhages inside the retina, which are pretty clear, these kind of red spots there, also called dot blot hemes, if you're in the ophthalmology world. And those are a giveaway that there's something going on with the blood vessels. It doesn't have to be diabetic retinopathy. There's other causes that, like high blood pressure can cause some hemorrhages in the retina. An eye stroke can cause hemorrhages in the retina as well. But it's by far the and age-related macular degeneration can too, but most commonly it is diabetic retinopathy, and we correlate with what else is going on with the patient to help figure that out. And then there's also in the bottom left of that photo, there's a CWS. It says it's cotton wool spots, which are little small areas of infarcted, meaning the blood vessels to that area are blocked, and it's a little tiny area of kind of tissue damage there. So those are all possible. Usually people don't have all of those at once necessarily, and it may just be a couple little tiny spots that I see, and I tell someone, hey, you have diabetic retinopathy, but hopefully we catch it early enough it's not affecting vision yet, and then can get blood sugar down before it starts affecting vision. So having diabetic retinopathy, once again, does not mean that your vision is, going to be, it does not mean you're going to go blind, and doesn't even necessarily mean the vision's affected at all. But if the vision is going to be impacted, this is the most common way that happens. It's called diabetic macular edema. Edema means swelling. Macula is that center area of the retina that's important for vision. So it's just swelling in the retina. This is an ocular coherence tomography image. You don't need to worry about that, but it's one of the ways that we can scan the retina. And that top image is normal. So where the green line is, this is a cross section through where that green line is. And you can see, this is a black and white version of that photo I showed you earlier, but the big, and it's facing the other direction, but the big black circle on the right side of the left portion of this image is the optic nerve. And then the kind of darker area in the middle is, once again, that's where the macula and the fovea is. And you can see that divot that I had a drawing of earlier. That's an actual photo of the divot, or scan of the divot there, that's how it should look. Those are a bunch of layers of the retina there. That all looks healthy and normal. Then if you look at the bottom picture, that's a pretty extreme example, but this is what can happen with the swelling in the macula. You can see that instead of a divot, now we have a big raised hump there. And that you could imagine if your body's used to being able to detect the light through just this really, really narrow area of tissue where that divot is in the center of your vision. If you have all this extra fluid in place and this lots of extra space, and even between the cells, they're now kind of spread out as this fluid is moving everything around. You can imagine that you don't see as well. Things are blurry when you have that fluid in the way. So this vision loss typically is relatively central. So if someone with diabetes comes in and they feel like, hey, my vision is just gotten blurry, and this is one of the most common reasons for that, and it can be a little bit off center sometimes, but usually relatively central. Now, what do we do about that? So thankfully, in the last 20 years, we've really had a revolution in treatments available for diabetic macular edema, or any type of macular edema. So getting rid of that swelling, we can now inject medications into the back of the eye. Sounds scary. Most people associate needles in the eye with torture, which is fair enough. But I promise you, we numb the eye up really, really well. Most of my patients don't even really know that it's happened when they're getting put the needle in because they're numbed up so well. But still, you want to avoid this if you can, of course. Mainly because it's an infection risk, actually, anytime you introduce something into the eye. But still, it's a very effective treatment for swelling in the retina. What we do when we inject is compounds. There's a bunch of brand names and their generic names there that you may have seen ads for or heard of. They're a big budget item in some pharmaceutical companies here. But all those different compounds act against VEGF, which is vascular endothelial growth factor. We don't have to go into that in too much detail, other than know that it makes blood vessels leaky and it makes new blood vessels grow. In this case, we're combating the leakiness of the blood vessels. That's fluid, that extra fluid in the retina came from these leaky blood vessels, and So the injections to block the compound that makes it leaky are the best way to treat that. The problem is these leaky blood vessels are going to keep making VEGF, so it's not a one and done deal. You have to often get multiple injections, and until you get blood sugars under better control, it's not a permanent solution. This medication will wear off. Often about once a month is usually the frequency of the injections, and then hopefully not permanently, but I do know people who over years have to keep getting these injections. Macular ischemia, really quickly, is just when there's not enough blood flow to the macula, which is a central part of the retina, and blood vessel damage eventually is going to result in not enough blood flow, which can trigger the growth of abnormal new blood vessels. This is where the proliferative name comes in. Proliferative meaning there's a proliferation of new blood vessels growing that shouldn't be there. The tissue that isn't getting enough blood sends out this SOS cry for help. Hey, I need blood. Can somebody help me? And the body responds by making new blood vessels. That sounds good, right? We got new blood vessels coming in. That's great. Actually doesn't work out, unfortunately. The new blood vessels don't have the right scaffolding. They don't have the right support structures to function properly, and they end up causing a lot of problems. Can get bleeds into the vitreous. The vitreous is a jelly that sits in the middle of the eye. It's normally clear. That's where floaters are. If you see those floaters floating around, they literally are floating in the jelly in the middle of your eye. So if you get blood, sometimes the blood vessels that can grow into the vitreous, bleed into the vitreous. If you get a small bleed, you might get a couple extra floaters. If you get a major bleed, you can go totally blind out of that eye, at least temporarily. It's like you're trying to look through a glass of red wine. Can't see anything. But the good news is it's not usually permanent. The blood will often resolve on its own. Sometimes requires surgery to get it out if it's not going away fast enough. The blood vessels that grow into the jelly in the eye, the vitreous, they often scar quite a bit. Like I said, they're abnormal. And when they scar, they can contract and tug the retina. Like I said, it's wallpaper. So it can peel off the back of the eye if it gets tugged on too hard. And that can happen with these abnormal blood vessels, can lead to retinal detachments, which can be really tricky to fix, often require surgery, can cause permanent blindness. And then neovascular glaucoma, discussed it earlier. It's when the new blood vessels grow all the way into the front of the eye. This is usually pretty severe, a proliferative diabetic retinopathy, that they grow all the way to the front of the eye. This is someone's iris, the blue part of the eye that is covered in these abnormal blood vessels that shouldn't be there. That around the iris is where the drainage system in the eye is. So that's where you run into problems with high pressure. Sometimes, anti-VEGF injections, those injections I was talking about earlier, can be used to treat proliferative diabetic retinopathy and decrease the new blood vessel formation, but that's not always enough. And sometimes you have to do laser into the eye. What the laser does is actually it disables a lot of the retinal tissue. Sounds bad. I mean, I wouldn't recommend it if you don't have severe diabetic retinopathy. But the reason that we do it is your retina covers a very large area in the eye. Like I said, the center retina is really what's important. So we can knock out a bunch of peripheral retina and have minimal impact on vision, and trying to save the central retina. Well, when you knock out that peripheral retina, you decrease the amount of VEGF that's being released, and you can permanently kind of decrease the chances of new blood vessels growing by permanently knocking out that peripheral, less important retinal tissue. And then surgery I touched on earlier can be used to clear up blood inside the eye or repair retinal detachments. It's kind of like laparoscopic surgery, if anyone knows what that is, where we have little ports we put into the eye and little instruments that we're manipulating into the back compartment of the eye just in front of the retina there. So takeaways from all of this. The eye is a really complex organ, like 12 subspecialties worth of ophthalmologists out there who would agree with me. And the diabetes can impact the eye in a lot of different ways. Most of it is preventable. Going back to those risk factors, time with diabetes, well, if you're diagnosed, you can't can't do anything about, you can't turn back the clock. But the second most important risk factor was how high the blood sugar is. So controlling blood sugar is really, really important, and decreasing the chance of any of these kind of bad things happening. And then also controlling your other vascular risk factors, high blood pressure, smoking, high cholesterol. Those are all, really important. So getting the regular blood work to screen for diabetes is very important. And then the eye exams to screen for eye problems, so that we can, catch this early and treat it appropriately when necessary. And as we've mentioned throughout the way, there's a lot of treatment options available for these complications of all kinds of diabetic eye disease. So it's never, no one should lose hope with one of these diagnoses, but prevention is certainly the best way to treat it. All right, thank you all for listening and taking any questions. Good question. So there's a lot of the tissues. Oh, sorry, let me repeat the question. I'm sorry. Thank you. The question was, why don't the parts of the eye undergo mitosis to just kind of replace and repair what's damaged? There is a lot of repair and replacement that happens where possible. Not all tissues can be replaced so easily, unfortunately. And I don't know if all of those, all of that's totally understood, but there's just a lot of different signaling molecules that are necessary for some of these cells to reach their, terminal state where they're functioning appropriately. And then there's also, with neurons, there's a lot of, everything's very interconnected. And so it can be hard for a new cell to grow into those same connections that a previous one had. But there's a lot of research going into whether we can regenerate some of these things, but it hasn't been successful in all areas.
Yeah, so in the background, they kind of mentioned how what inspired you was kind of Anna forming eye cancer. I was kind of wondering from perspective of like international medicine, how does eye care operate? What kind of that perspective, and then also second question would be like, what are some developments or technologies that you really see that?
Question was about global eye care, global outreach, ophthalmology and eye care, and then also what new technologies are coming that excite me in the field. So in terms of ophthalmology is actually pretty well geared towards global outreach. A lot of these surgery, so like cataract surgery, for example, can be done relatively quickly, meaning you could see a lot of folks in one day and help a lot of people. And it's a relatively, as far as surgeries go, it's a relatively easy surgery to recover from, meaning that just a couple of follow-up visits and people are usually kind of good to go after cataract surgery. So cataracts are one of the big areas where global outreach has been really successful. A lot of different models for that. The organization I was volunteering with was focused on, it was called Unite for Sight. It was started by a Yale grad, but it was focused on supporting Ghanaian ophthalmologists, so supporting local ophthalmologists in these countries to help them stay in the countries where they're from, as opposed to going to other countries where they might make more money, but helping support that and providing resources for people who wouldn't normally be able to afford to get some of this care, to get that care. But there are also a number of successful setups where like American surgeons fly into different locations. There's ethical concerns with that. It has to be done right. Make sure people are getting proper follow-up after surgery, and that it isn't a training grounds for, trainees to just kind of try out new techniques or something like that. That would be the dark side, the worst part of possible things. But there's a lot of really well-run global outreach ophthalmology. UNC, Dr. Boudens, who just moved on from UNC, but he was running a trip to Ghana, actually, the UNC ophthalmology department. And then at Duke, Lloyd Williams travels all over the world and does a lot of really good work with that. If you're interested in looking that up, actually, Lloyd Williams at Duke would be a great person to look into. In terms of new coming technologies that excite me, they just did the first robotic cataract surgeries. I'm cautiously optimistic about those. I mean, I don't want to be totally replaced by robots, but there's a lot of people out there who need cataract surgery, and it's still piloted by a human. But so that's a very interesting. There's robotic surgery in a lot of other parts of medicine, but previously the cataract surgery was too fine. The level of intricate detail was too fine for robots previously, but they just now did some of the first robotic surgeries. So that's not like FDA approved. It's not publicly available yet, but I'm curious to see where that goes. The back.
I never gone to an ophthalmologist, but he's talking about macular degeneration. Is he just dumbing down the ultimate message?
So the question is about macular degeneration and the different types, wet versus dry, and optometrist versus ophthalmologist care. So macular degeneration, there are two big categories, wet and dry. That's accurate. Dry is the earlier stage, wet is the more advanced stage. Actually, a lot of what I talked about today in some ways applies to wet AMD. Wet macular degeneration is a lot like proliferative diabetic retinopathy. It's when new blood vessels start growing in that area, whereas dry is that's different from the non-proliferative. But there are different stages of dry macular degeneration, and some of which can be really visually devastating. Like there's something called geographic atrophy, which can cause really severe vision problems. So there is nuance within the wet and dry grades, and I would say, ask if you were told that you have dry macular degeneration, but ask what stage is it. There's mild, intermediate, and advanced dry macular degeneration. In terms of optometry versus ophthalmology, there with mild macular degeneration, I think an optometrist could be suited to handle that. If it was advancing beyond that, I would certainly see an ophthalmologist, and you could always see an ophthalmologist at least once to make, because I recommend second opinions for all kinds of folks for all kinds of things. So that could be sort of a second opinion for you, and then maybe go back to the optometrist after that.
Righty. Unfortunately, we are out of time and sort of need to wrap things up, but if we could get a round of applause for Dr. And we'll see you next week or next month, hopefully.
Yeah, we hope to see you for our talk on next month. So thanks.